So I am starting today's class. So about the superior extremity. So please communicate with me by using the comment section, commenting in the comment section. So about the superior extremity, first about the parts of upper limb. So there are some parts of upper limb. This is the shoulder region, arm, forearm, and hand. So shoulder region is containing pectoral region, axilla, and scapula region. So in the shoulder region, there are two bones. One is clavicle and one is scapula. So, and there are two joints, sternoclavicular joint and acromioclavicular joint. In the arm, there is one bone humerus, and there is one joint is called shoulder joint. And in case of forearm, there are two bones, radius and ulna, both of them giving rise to two joints, elbow joint and radioulnar joint. And in case of hand, there is wrist joint, and there are a part called wrist, hand proper, forming with the metacarpal bones, and digits. And hand consisting of carpal bones, metacarpal bones, and phalanges. There are several joints in the hand, like wrist joint. Wrist joint is also called radiocarpal joint. So you will be asked in the Viva examination, is there any contribution of ulna in case of wrist joint? So the answer is no. There is no contribution of ulna in case of wrist joint. There is only radius and carpal bone are engaged in formation of wrist joint. So there are intercarpal joint, carpometacarpal joint, intermetacarpal joint, metacarpopharyngeal joint, and proximal and distal interpharyngeal joint. Moving on to the next slide. So this is the lines of force of transmission. So it can be asked in the Viva examination. So the weight transmits through first starting from the hand, then moving on to the wrist joint, then coming to the radius, then through the interosseous membrane it goes to the ulna, and from the ulna it goes to the elbow joint. Passing into the elbow joint, the force goes to the humerus, and humerus transmits this weight to the shoulder joint, and from shoulder joint it goes to the scapula, and scapula transfer this weight through coracoclavicular ligament, which is attached into the clavicle, and this force goes to the clavicle, and then clavicle passes it to the sternoclavicular joint, and through the sternoclavicular joint it goes to the sternum, and actually it goes to the axillary skeleton. So this is the line of force of transmission. So this is the basic thing. So these are the joints. This is the shoulder joint, this is the elbow joint, this is the wrist joint, and these are the bones consisting of the superior extremity. I will talk about only the Viva questions today. So you have already read about this. So this is the revision class. So I will put emphasis on the Viva questions exactly. So this is the clavicle, starting with the bones. This is the clavicle. You will be asked, you already know about the anatomical positions and how to hold the clavicle in an anatomical position. What are the Viva questions? The most important questions in case of clavicle. So after holding the bone in an anatomical position, you will be asked about the peculiarities of clavicle. What are the peculiarities? It is the only long bone which lies horizontally. It is the modified long bone. Which type of bone it is? We find it just beneath our skin, and it is the first bone to start ossifying and the last bone to finish the ossification. So it is the only long bone that ossifies by two primary ossification center. So these are the common peculiarities. The peculiarities are very much important questions for Viva. And there is also an important question. There is trapezoid region, coronary tubercle. So So there is trapezoid ridge and conoid tubercle here. So if the connection is lost, please let me know in the comment section. So you will be asked about the attachment of trapezoid ridge and conoid tubercle. So the attachment is coracoclavicular ligament, and coracoclavicular ligament, if it is teared, and what will occur? There will be no transmission of weight from the upper limb to the trunk. So this is the subclavian group for subclavian muscle. So which muscle attached here? Subclavian muscle gets inserted here. So this is the muscle attachment. So you will be asked about the muscle attachments. So what are the important muscles attached in the clavicle? There is medial 2/3 and lateral 1/3. So in the medial 2/3 there is anterior surface. In the anterior surface of the medial 2/3 there will be origin of pectoralis major muscle. In the superior surface there will be sternocleidomastoid muscles. So in case of lateral 1/3 there is anterior border and posterior border. The anterior border gives attachment to the deltoid origin, and the posterior border there will be insertion of trapezius muscle. So you will be then asked about the nerve supply of this muscle. Deltoid muscle is supplied by axillary nerve. Then axillary nerve coming from which cord? The next question. Axillary nerve coming from the posterior cord of the brachial plexus. And what will occur if the axillary nerve is got damaged? Then the deltoid muscle will be paralyzed, and the function of deltoid muscle in case of shoulder joint is the abduction from 15 to 90 degree. It will be lost. So what is the nerve supply of trapezius? It is supplied by spinal accessory nerve, and sternocleidomastoid is also supplied by spinal accessory nerve. So these are the important questions related to the clavicle. So moving on to the next slide. The fracture of the clavicle most commonly occur at the junction between medial 2/3 and lateral 1/3. It is asked in the Viva question. So this is a figure showing the clavipectoral fascia. This is another important topic for your Viva. So about clavipectoral fascia, this is the fascia which encloses two muscles actually, subclavius muscles and pectoralis minor muscles below, and after covering these muscles it will go and merge with the axillary fascia below and merge with the investing layer of deep cervical fascia above. So this is the clavipectoral fascia related to the clavicle and the pectoralis minor muscle. So moving on to the next slide, next figure. What are the structures passing the clavipectoral fascia? It is the mnemonic is TCL. So by T it is thoracoacromial artery, by C it is cephalic vein, and by L it is the lateral pectoral nerve. And there will be lymphatics passing the clavipectoral fascia. Moving on to the next slide. This is another bone it's called scapula. So scapula, after holding it in the anatomical position, you have to know about the features of scapula. You already know about the features. The scapula, there are two surfaces, dorsal surface and costal surfaces. So this is the glenoid cavity. So you will be asked in the Viva how the shoulder joint is formed. So you have to tell that the head of the humerus and the glenoid cavity of the scapula. So there is shoulder joint. Which type of joint it is? It is ball and socket type of synovial joint. So which type of cartilage is covered in the glenoid cavity? It is called glenoid labrum. It is hyaline cartilage. So this is a notch called suprascapular notch. It is asked in the Viva question. What are the structures passing through the suprascapular notch? The suprascapular nerve and vessels passes through it. So there are three angles: inferior angle, superior angle, and lateral angle. Coming on to the muscle attachment of scapula, these are the muscles you will be asked in the Viva examination. The most important muscles are, I will name the important muscles here, from lateral to medial border at the dorsal surface, starting from here, teres minor, teres major, origin, then latissimus dorsi, insertion, then rhomboideus major, rhomboideus minor at the level of spine, and the above the level of spine it is liver scapulae inserted here. So the from lateral to medial it will be asked for the muscle attachment of the borders, and in the surface, in the dorsal surface there will be infra spinatus, and in the costal surface there will be subscapularis muscle originates. And the costal surface there will be one muscle, it is called serratus anterior. There will be insertion of the serratus anterior in the medial border of the scapula. So then you will be asked about the nerve supply of the how many digits of serratus anterior got inserted here. There are 8 digits got inserted here. So what is the nerve supply of serratus anterior? The nerve supply of serratus anterior is long thoracic nerve. Long thoracic nerve coming from the root of the brachial plexus. So what will occur after the injury of serratus anterior muscle? There will be winging of scapula. So these are the flow of questions in the viva examination. The important muscle about the coracoid process. What are the muscles got attached in the coracoid process? There is short head of biceps brachii and coracobrachialis muscle. And there is a ligament also, coracoclavicular ligament and suprascapular ligament. So these are the, and about the glenoid cavity, there is supraglenoid tubercle and infraglenoid tubercle. This is very much important. You will be asked in the viva examination. In the supraglenoid tubercle, are you all getting me? You all are with me now? Please let me know in the comment section. Is it clear to you up to this point? Please let me know in the comment section. Please interact me in the comment section, so it will be easier for me to understand, to continue. So the supraglenoid tubercle gives attachment to the long head of biceps, and the infraglenoid tubercle gives origin to the long head of triceps. Shreya, thank you. So these are the important questions about the scapula. So this is a figure showing the winging of scapula. Actually these are the two figures, both of them are showing the winging of scapula. So paralysis of the serratus anterior causes winging of scapula. I've already mentioned earlier. The medial border of the bone, look here, the medial border of the bone becomes unduly prominent. It looks prominent, and the arm cannot be abducted beyond 90 degrees in case of winging of scapula. The scaphoid scapula is a developmental anomaly in which the medial border is concave. So this is a very much important clinical question for you in the viva examination. Moving to the next bone, it is the humerus. So humerus, after holding it and telling the anatomical points, all these things, you will be asked about the anatomical shoulder joint, and you will be asked about the neck. How many types of neck? Anatomical neck, morphological neck, and surgical neck. So surgical neck is the most important thing. So what is the importance of surgical neck? So fracture frequently occurs at the level of surgical neck. So here at the level of surgical neck, there is axillary nerve is related, and at the shaft there is radial groove. Here radial nerve is related, and at the prominent medial, just behind the prominent medial epicondyle, there will be ulnar nerve related. So if the surgical neck is fractured, the axillary nerve will be got damaged, and axillary nerve, if axillary nerve got damaged, then there will be the axillary nerve supplies how many muscles? 2 muscles. It will be asked in the viva question, very important question. 2 muscles supplied by axillary nerve. These are deltoid and teres minor. So deltoid muscle will be paralyzed, and there will be 15 to 90 degree abduction of the shoulder region will be failed. So these are the features showing humerus. So bicipital groove. So you will be asked about the attachment of bicipital groove. You will be asked about the attachment of, here the bicipital groove showing lateral lip, medial lip, and floor. The lateral lip gives insertion to the pectoralis major muscle. 2 major, medially teres major, and the floor there will be latissimus dorsi. It is very much important, and the most important muscle in the humerus is called brachialis. At the anterolateral anteromedial surface, at the lower portion of the bone, there will be origin of brachialis. Then you will be asked about the muscle further. So what is the nerve supply of brachialis muscle? The brachialis muscle is supplied by, there are dual nerves supplied by brachialis muscle. One is musculocutaneous nerve coming from the lateral cord of the brachial plexus, and one is radial nerve coming from the posterior cord of the brachial plexus. So there are two nerves supplying the brachialis muscle. And then we will be asked, what is the main chief function of brachialis? The chief function of brachialis is, it is the chief flexor of elbow joint. So brachialis is the chief flexor of elbow joint. So remember this. These are the very much important questions for you in the Viva. And deltoid tuberosity. This is the deltoid tuberosity. Deltoid muscle will be got inserted here. So then you will be asked about the deltoid muscle. I have already discussed. About the coracobrachialis muscle, it is got inserted here. Coracobrachialis muscle, it got pierced by a nerve. It is called musculocutaneous nerve. So these are the muscles of arm. These are the important things, and you will be also asked about what are the articular structure at the lower end of the humerus. So the articular structure in the lower of the humerus are capitulum and trochlea. Capitulum got articulate with the head of the radius, and trochlea got articulated with the trochlear notch of the ulna. So this is about the humerus. Humerus is a typical long bone. So this is a figure showing the rotator cuff at the shoulder joint. It gets stability to the shoulder joint, and four muscles forming the rotator cuff, fibrous sheath. What are the four muscles? Supraspinatus, infraspinatus, teres minor, subscapularis. So you will be asked which portion of the shoulder joint is weak. The inferior portion of the shoulder joint is weak because there is no support, muscular support in the inferiorly. So the dislocation of the shoulder joint will occur frequently inferiorly. Okay, Rajiv, I can't repeat now the going of scapula because I have a short time. You can repeat the video after finishing the class. Okay. So now I've already told about the nerves related to the humerus. So axillary nerve is coming from the posterior cord of the brachial plexus. It is very much important. Radial nerve coming from also from the posterior cord of the brachial plexus, and ulnar nerve also coming from the medial cord of the brachial plexus. So now about the nerve injuries. So if the radial nerve got injured, then it is called wrist drop or Saturday night palsy. Okay, so look, the sitting in the table like this will compress the radial groove, and the radial nerve gets injured like this, or using a crutch like this. So there will be Saturday night palsy, or also called wrist drop. So wrist drop occurs in case of radial nerve injury. And in case of ulnar nerve injury, the nerve coming from the medial cord of the brachial plexus, there will be claw hand. So in case of claw hand, there will be hyperextension of the wrist joint, hyperextension of metacarpopharyngeal joint, and flexion of the interpharyngeal joint. So like the paw of the cat, it is called claw hand. Then this is the ulnar nerve injury. Sensory loss occurs at the level of fifth and fourth finger level, periphery to the palmar surface and dorsal surface. Then moving on to the next nerve, it is called median nerve. So median nerve got injured, and it is called benediction deformity of the hand, and where thumb rotated laterally, and this is called ape thumb deformity. And these are the areas where the sensory loss occur in case of median nerve injury. So going to the next bone, it is radius and ulna. So about radius and ulna, so these are the bones of forearm. So after holding the bones and telling the anatomical points, you have to, the most important key questions of these bones are, there is radial tuberosity here. So radial tuberosity very much important. There is rough area of pronotor, it is very much important. There is ulnar tuberosity, it is very much important. And there are two processes, olecranon process and coronal process. These processes are important for Viva. So dorsal tubercle is important in case of radius, which lies posteriorly at the lower end. And at the inferior surface of the lower end of the radius, there will be impression for scaphoid and lunate. It is asked in the Viva examination. So there will be radiocarpal joint. So this is a figure showing the features of upper end of the ulna. This is the trochlear notch which lies directed forward. It is the medial bone of the forearm, ulna. It is, and here the radial notch where the upper end of the radius got attached and forms the superior radial ulnar joint, which is a pivot variety of synovial joint. So this is the olecranon process and this is the coronal process. Moving on to the muscle attachments. What are the muscle are important in case of radius and ulna? So here at the radial tuberosity, biceps brachii inserted. Very much important question for you. Biceps brachii got inserted in the radial tuberosity. What is the nerve supply of biceps brachii? It is musculocutaneous nerve coming from which cord? It is coming from lateral cord of the brachial plexus. So supinator muscle, which is responsible for supination, got inserted here and got originated in the ulna. And here at the ulnar tuberosity, there is brachialis muscle got inserted. It is very much important. I have discussed earlier about the brachialis muscle. And at the lower end of the radius and ulna, there is pronator quadratus. So in insertion, it gets inserted in the radius and got originated in the ulna. So there is another important muscle at the upper surface of the olecranon process. This is called, the muscle is called triceps. Triceps gets attached, inserted in the upper surface of the olecranon process. So it is the muscle of back posterior aspect of the arm. The nerve supply of triceps is radial nerve coming from the posterior cord of the brachial plexus. So these are the important things. So here clinical topic related to the radius. There is Colles fracture and Smith's fracture. So radius commonly gets fractured about 2 cm above its lower end. Is called Colles fracture. When a person falls on outstretched hand, this fracture occur. And there is another figure showing, this is called Smith's fracture. So Colles fracture is more important for you. If the distal segment gets displayed anteriorly, it is called Smith's fracture. So moving on to the next slide, it is the articulated hand. I have already discussed about the articulated hand in the previous class. So the first thing you will be asked after telling the anatomy, holding the bone in the anatomical position is, how many sets of bones are there? There are 3 sets of bones: carpal bones, metacarpal bones and phalanges. So then the next question will be, identify the carpal bones. What are the carpal bones? Then you have to, how many rows are there? There are 2 rows, proximal row and distal row. So there are 4 bones in the proximal row and there are 4 bones at the distal row of the carpal bones. So for which type of bones are carpal bones? These are the short bones. Then you will be asked about which type of bone it is. These are the short bones. So then the next question will be, what are the criteria of short bones? So short bones are, they are having 6 surfaces. Among them 4 are articular surface and 2 are non-articular surface, and they are irregular in shape. So coming to the metacarpal bone, you will be asked about the epiphyseal end and growing end of the metacarpal bone. All of the metacarpal bone containing the epiphyseal end or growing end at their head except the first one, the first metacarpal bone having their epiphyseal end or going in at the base. So it is very much important question for Viva. So metacarpal bones are miniature long bone having one epiphysis, and typical long bone having two epiphyses. So these are the phalanges. Phalanges are also miniature long bone. There are 14 phalanges in case of hand. There is proximal phalanx, distal phalanx and medial phalanx in case of 4 fingers except the thumb. So you will be asked about the joints of the hand. So I will discuss about the joint further in later on. So there is pisiform. Pisiform is a sesamoid bone. You will be asked about the sesamoid bone. The largest sesamoid bone is patella. Or the cardio of sesamoid bone. Sesamoid bone, they have no medullary cavity. They have no Habachian system. They develop from the muscle tendon. Then you will be asked from which muscle tendon it develops. Flexor carpi ulnaris. So these are the muscle attachment. Then this is the figure showing, this is a tunnel formed by the carpal bones. It is called carpal tunnel, and there is flexor retinaculum goes attached. You will be asked in the Viva how the where the flexor retinaculum got attached. So there is medial attachment and lateral attachment of the flexor retinaculum. So just under the deep to the carpal tunnel, there will be one nerve, single nerve pass, because it is called through median nerve. So if the median nerve goes compressed, there will be a syndrome called carpal tunnel syndrome. So sometimes there is a extra digits. If there is extra phalanx in case of thumb, there will be 6 digits in this individual person. It is called polydactyly. So the person having 6 fingers, 6 digits called polydactyly. So the lateral branch of has a distal epiphysis and 3 phalanges. Total digits are 6 in such case. Moving on to the next figure, next slide is showing the muscles. So muscles of upper limb in a tabulated form. So you have to know all the name of the muscles here. In the pectoral region, what are the muscles of pectoral region? You will be asked in the Viva, what are the muscles of pectoral region? The muscles of pectoral region are pectoralis major, pectoralis minor, subclavius muscle, and serratus anterior. So pectoralis major and minor is supplied by medial and lateral pectoral nerve. Okay, and the muscles of vertebral column, these are the trapezius, latissimus dorsi, lepidoscapulae, rhomboideus major and minor, or muscle of scapula region also. So nerve supply of trapezius is spinal root of accessory nerve. Latissimus dorsi, about latissimus dorsi, it is called climbing muscle, and the nerve supply of latissimus dorsi is thoracodorsal nerve. Is everything clear to you up to this point? I am going in a hurry way because time is very limited. But topic, I have to cover the whole card in a single hour. So I am going a bit hurry. So please let me know if there are any problem, and is it clear to you up to this point? Okay, very good, Rahi. So next, going to the scapular region, here supraspinatus, infraspinatus, teres minor, subscapularis and teres major. These are the muscles. So you have to know the nerve supply of these muscles also. Here teres minor is supplied by axillary nerve. And in case of arm, the anterior compartment of the arm, having 3 muscles, coracobrachialis, biceps brachii and brachialis. So the muscles are supplied by musculocutaneous nerve except brachialis, which is supplied by double nerve supply, radial nerve also with the musculocutaneous nerve. And the posterior compartment of the arm having single muscle called triceps brachii, having 3 head and supplied by radial nerve coming from the posterior cord of the brachial plexus. So here about the front of the arm, there are some superficial muscle, 5 superficial muscle in the front of the forearm. From lateral to medial, these are the pronator teres, flexor carpi radialis, primaris longus, flexor digitorum superficialis, and flexor carpi ulnaris. So, except flexor carpi ulnaris, all the muscles are supplied by median nerve, and flexor carpi ulnaris, as it is called ulnaris, it is supplied by ulnar nerve. And median nerve coming from two roots of the brachial plexus, both the lateral cord and medial cord. Two cords actually, both the lateral cord and medial cord of the brachial plexus. And what are the deep muscles? There are 3 deep muscles in case of anterior aspect of the forearm. One is flexor digitorum profundus. Profundus means deep. Flexor pollicis longus. Pollicis means thumb. Pronator quadratus. Quadratus means also. And pronator means it is responsible for pronation. So these muscles, flexor digitorum profundus is supplied by 2 nerve, ulnar nerve and anterior interosseous branch of median nerve. And flexor pollicis longus and pronator quadratus, both of them are supplied by deep branch of median nerve, anterior interosseous nerve. Coming to the back of the forearm, the superficial muscles are, there are 7 muscles: Anconius, brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris. So here 3 muscles are supplied directly by the radial nerve. They are so here 3 muscles got supplied by directly by the radial nerve, and the other muscles are supplied by deep posterior interosseous branch of radial nerve, which is one is the deep branch of radial nerve. And there are 5 deep muscles of the forearm. These are the supinator muscle, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and extensor indicis. These all muscles are supplied by posterior interosseous branch of radial nerve. So coming to the hand, here there are thinner muscle and hypothinner muscles. So in case of thinner eminence, there are abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis. And there is one adductor of thumb, this is adductor pollicis. And in case of hypothinner muscle, these are supplied by median nerve, the thinner muscles, and the hypothinner muscles, there is palmaris brevis, abductor digiti minimi, flexor digiti minimi, opponens digiti minimi. These are supplied by superficial branch of ulnar nerve. So these are all about the muscles. I think I have told every points, every muscles. It is not necessary to know about the nerve supply of every muscles. The more important muscles and the larger muscles are very much important for Viva. So this is a figure showing the dissected back portion of the body. Here, this is the infraspinatus muscle. This is the Latissimus Dorsi. Which one is the climbing muscle? Here it is the trapezius diamond-shaped muscle, and this is the deltoid muscle at the back. So this is the figure showing the dissected portion of the anterior aspect of the forearm. So here this is the brachial radialis from lateral to medial. This is the brachial radialis. There is radial nerve. There is biceps brachii tendon. There is pronator teres. So there is a cubital fossa here. So lateral boundary is the brachial radialis. The medial boundary is the pronator teres. And this is the brachial artery here. And this is the median nerve. So here the muscles are shown here. Here the muscles of thinner eminence. This is the flexor carpi radialis muscle going to the radius at the level of radius. These are the flexor digitorum superficialis and profundus tendon going to the digits. and profundus mean deep, and flexor carpi ulnaris muscle going to the ulna, and responsible for all the muscles are responsible for flexion. This is the figure showing dissected portion of the back of the forearm. So here extensor digitorum, abductor pollicis longus and extensor pollicis brevis are shown. Extensor carpi ulnaris at the level of ulna and extensor digiti minimi. So anatomy is all about the figures. So you have to look around the figures all the time to make the anatomy learn as easy as possible and with fun. Is there any problem with the connection or with the video? Please let me know. Are you getting the streaming smoothly or there is some interruption? Please let me know. Okay, so moving on to the streaming is clear, streaming is fine, smooth. Then these are the muscles. This is the pectoralis muscle, fan-shaped muscle in the pectoral region. This is the biceps brachii. Laterally, the longest lies laterally, the shortest lies medially, and deep to the biceps brachii there will be brachialis muscle, and these are the serratus anterior, digits of serratus anterior muscle. This figure showing the biceps, the arm, and it is the pectoralis minor muscle just below the pectoralis major muscle. So this figure showing the deep muscles of the arm. This is the biceps brachii, and the deep to the bicep there is brachialis. This figure showing the back muscles. This is the diamond shaped trapezius muscle, and which has got three parts: descending part, transverse part, and ascending part. This is the latissimus dorsi muscle, and here this is the deltoid muscle, and this is the triceps muscle having three heads, long, and this is the triceps muscle having three heads, long head, lateral head, and medial head, supplied by radial nerve. This figure showing also the back muscles. This figure showing the muscles of scapular region. I have already told about the muscles earlier, the anterior compartment of the muscles. There are 5 superficial muscles and there are 3 deep muscles in case of anterior compartment of the forearm. So these figures are showing the muscles of the forearm. So these figures are for visualization. This figure showing the deep muscles of the forearm of the anterior compartment or flexor compartment. Flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. So this figure showing the deep superficial and deep muscle of the posterior compartment of the forearm. So here extensor carpi ulnaris, all the extensor muscle will be there. Extensor digitorum, extensor digiti minimi. Okay, then the extensor pollicis brevis, extensor pollicis longus, extensor indicis for the index finger. So I will skip these slides because I have already mentioned about these slides earlier, muscles. So coming to the joints. Coming to the joints, first it is the sternoclavicular joint. Here, the medial end of the sternum got attached to the clavicular notch of the clavicle, manubrium sterni, and forms the sternoclavicular joint, which is saddle radial synovial joint. And this is the acromio-clavicular joint, which is plain radial synovial joint. These are the very much important questions. This is the shoulder joint. So shoulder joint So you can say shoulder joint. It is the ball and socket radial synovial joint. What are the movements of shoulder joint? I will show you in the further slide. These are the movements of shoulder joint. So this is the flexion, extension. This is the way to show. This is the flexion. This is the extension. Okay. This is the medial rotation. This is the lateral rotation, and there will be. This is the adduction. This is the abduction, and this is the circumflexion. So this figure showing all the movements of the shoulder joint. You have to show the movement of the shoulder joint. This is the elbow joint. Elbow joint is the uniaxial joint. It is hinge variety of synovial joint. Two movements occur here. One is flexion, one is extension. So then you will be asked about the which muscle is the chief flexor of the elbow joint. Is the brachialis, and which one is the extensor of the elbow joint? It is triceps. So supination pronation. Supination pronation is the movement of superior and inferior radial joint. So see at the figure, superior inferior radial joint. So then you will be asked, what are the muscles responsible for supination and what are the muscles responsible for pronation? So supination, in case of supination, the king's pronate and the person which takes it supinates. So the king's pronate, the hand should be like this, and the elbow joint will be semi-flexed. The muscles responsible for supination are supinator and biceps brachii. Then you will be asked which one is the chief supinator. The chief supinator muscle is biceps brachii. And what are the pronator muscles? Pronation muscles. Muscles for pronation. These are the pronator quadratus and pronator teres. So this is showing the superior inferior radial joint, and this is the middle radial joint, which one is syndesmosis variety of synovial joint. Syndesmosis variety of fibrous joint. Sorry. So now coming to the movement of the thumb, you have to show the movement of the thumb. How you will show? This is the flexion. The opposite one is extension. This is the adduction. So putting the thumb closer to the other fingers and away from the other fingers, it goes away from the other fingers at 90 degree. It is called abduction, and counting movement is called opposition. So these are the movement of thumb. You have to show the movement of thumb in the by examination. It is very much important. So this figure showing the movement of the scapula. When you will hold the scapula, you have to show the movement of the scapula. So there are 6 movements over there. One is protraction, moving in this direction, and moving in the upward direction is retraction, and in the above direction it is like elevation, where the scapula is elevated, and where it is depressed. When there will be weight in the limb, there will be depression of the scapula, and there is medial rotation and there will be lateral rotation. So these are the 6 movements of the scapula. This is the figure showing the artery supply of the. This is the artery supply of the figure showing artery supply of the upper limb. So here I am coming from the start from the heart. The heart in the arch of aorta giving rise to 3 branches. One is brachiocephalic trunk, left common carotid artery, and left subclavian artery. Brachiocephalic trunk going to the giving rise to the right subclavian artery and right common carotid artery. So subclavian artery, when it passes the outer part of the first tip, it becomes the axillary artery, and axillary artery, when it comes to the lower border of the teres major muscle, it becomes the brachial artery. When the brachial artery comes to the neck of the radius, it gives 2 branches. One is radial artery and one is ulnar artery. And radial artery becomes deep palmar arch and ulnar artery becomes superficial palmar arch at the hand. So these are about the artery supply of the upper limb. So in case of measuring the blood pressure, we use the artery. We measure the blood pressure by using the brachial artery, by palpating the brachial artery. I will go to this in the next session. Next slides. So this is the figure showing the venous drainage of the upper limb. There are some superficial vein and deep veins in case of upper limb. So what are the superficial veins? There are basilic vein medially, the basilic vein medially, it is the superficial vein, and laterally is the cephalic vein, superficial vein, and there is the vein connecting these two veins is called median cubital vein. This median cubital vein will be asked in the viva examination. It is important for intravenous injection, infusion, and blood transfusion. So it lies superficially. And which one is the deep vein? There is the axillary vein. So all the superficial veins will drain into the axillary vein, and axillary vein will drain into the subclavian vein, and subclavian vein and with the internal jugular vein they will form brachiocephalic vein, and brachiocephalic vein, right and left brachiocephalic vein will form superior vena cava and draining into the right atrium of the heart. So going to the next figure, this is the figure showing boundary and content of axilla. You will be asked in the viva about the boundary and content of axilla. So the contents are by the name of axilla. There will be axillary artery, there will be axillary vein, there will be three cords of brachial plexus, posterior cord, lateral cord, and medial cord, and there will be axillary tail of waist. These are the contents of axilla. I am just revising, giving a review for you for that tomorrow's viva examination of superior extremity card final. So this is the figure showing the axillary artery. Axillary artery has got some branches and got three parts actually. These are the first. This is the first part of axillary artery. This is the second part of the axillary artery. This is the third part. How will you divide these three parts? By the pectoralis minor muscle. So this is the pectoralis minor muscle. So before the pectoralis minor muscle, this one is the first part, and within the pectoralis minor muscle it is the second part, and just after the pectoralis minor muscle this is the third part. So what are the branches of the axillary artery? From first part, this is the superior thoracic artery, and from the second part there are lateral thoracic artery. There is also other branches like posterior circumflex humeral artery and anterior circumflex humeral artery and subscapular artery, coming from the third part of the axillary artery. So these are the branches of axillary artery. You have to know the branches of axillary artery. This is the figure showing the brachial plexus, very much important for written and viva also. You have to know about the cords of the brachial plexus and different nerves coming from the different cords of brachial plexus. The most important nerves are like axillary nerve coming from the posterior cord, radial nerve coming from the posterior cord, ulnar nerve coming from the medial cord of the brachial plexus, and musculocutaneous nerve coming from the lateral cord of the brachial plexus. So these are the most important nerves of the coming from the brachial plexus. You will be asked in the viva examination. So the next one are the branches of brachial plexus. So what are the branches? From the root there will be two nerves coming from the root. This is the long thoracic nerve, or called nerve to serratus anterior. You have to know the root value of the muscles. So the root value of this nerve, so the root value of the long thoracic nerve is cervical 5, 6, 7. Dorsal scapular nerve is cervical 5, and two nerves coming from the trunk. One is suprascapular and one is nerve to subclavius. And from lateral cord there will be lateral pectoral nerve, lateral root of median nerve, and musculocutaneous nerve. So you have to know the root value of these muscles. You will be asked in the viva examination. And from medial cord, I will just mention the most important nerves. The most important nerves are radial nerve, axillary nerve, musculocutaneous nerve, and ulnar nerve. So, and also the long thoracic nerve. So you have to know the root value of these nerves. Okay. So moving on to the next slide, I have to be a little bit hurry because I've got very little time. So this figure showing the upper trunk injury and lower trunk injury of the brachial plexus. The upper trunk injury resulting in the Erb's paralysis, and the lower trunk injury of the brachial plexus giving rise to the Klumpke's paralysis. So policeman receiving a tip position, it is in case of arms paralysis. So in case of, it is the figure showing the features of both the arms and Kampke's paralysis. So the upper trunk formed by the cervical 5 and 6 and the lower trunk formed by the cervical 8 and thoracic 1. In case of upper trunk injury, there will be Apps paralysis, and in case of lower trunk injury, there will be Kampke's paralysis. So this is the figure showing anatomical snap box. So anatomical snap box, there is bounded by 3 tendons, muscle tendons. One is, there is that's below the extensor reticulum, there will be tendon of extensor pollicis longus. Pollicis means thumb. There will be tendon of extensor pollicis brevis. There will be tendon of abductor pollicis longus. And in the anatomical snap box, there is an artery. It is called radial artery. It is very much important clinically because we palpate the radial artery and exact the location of anatomical snap box. And also there will be tenderness if there is fracture of scaphoid bone, if there will be tenderness in the anatomical snap box. So radial nerve palpation is located in the anatomical snap box, and palpation of radial artery, we palpate the radial artery at this point. This is the figure showing the doctor measuring the blood pressure of patient. So we use a cuff at the level of arm and put a stethoscope, bed of the stethoscope at the level of brachial artery, so we can measure the blood pressure. So this is the figure showing the cubital fossa and the median cubital vein, which one is used for the intravenous injection and also blood transfusion. This figure is showing the deltoid muscle used for intramuscular injection, and deltoid muscle is used by abducting the shoulder joint, because the function of deltoid muscle is to move the shoulder joint from 50 to 90 degree. So abduction of 15 to 90 degree is occurred by the deltoid muscle. It is supplied by axillary nerve coming from the posterior cord of the brachial plexus. So my dear students, moving on to the next slide, this is the figure showing the complete claw hand. The combination of the lesions of median and lateral ulnar nerve injuries, it will resulting in the complete claw hand. So this is also a very important feature. So there are some important interesting facts for you. I have gathered these facts for you. These are very important informations, like axillary, radial and ulnar nerves are intimately related to humerus and are liable to be injured. Radial pulse is felt close to the lower end of shaft of radius, and pisiform bone is a sesamoid bone, I have already mentioned earlier, and in tendon of the flexor carpi ulnaris. These are the very much important viva questions for you. First metacarpal is the shortest and strongest and metacarpal of the metacarpals, and it is situated at an angle to the other bones, thus permitting opposition of the thumb. Third metacarpal is the longest, and the axis of the abduction and adduction passes through this center. So the third metacarpal is from the axis. Pectoralis major forms part of the bed of the mammary gland, and 75% of the lymph from mammary gland drains into axillary, and 20% of the anterior thoracic and 5% into posterior intercostal lymph nodes. So, and pectoralis minor muscle I have already showed in the previous figure. The pectoralis minor muscle dividing the axillary artery into 3 parts: first part, second part, and third part. So, my dear students, in the next slide, there is some information related to the median nerve. Triceps brachii is the only active extensor of elbow joint. Gravity extends the joint passively. Biceps brachii is the strong supinator. I have already mentioned the chief supinator muscle is biceps brachii. Sternoclavicular joint is the saddle variety of synovial joint, and movement of the shoulder girdle helps the movement of shoulder joint during 90 to 180 abduction. So the mechanism of abduction is already asked in the Viva examination. So 15 initiation of the abduction starts by the supraspinatus muscle, and 15 to 90 degree abduction brought by the deltoid muscle, and above 90 to 180 degree abduction is made by serratus anterior muscle and trapezius muscle. So shoulder joint is freely mobile and is vulnerable to dislocation. So there are some important points. I've already mentioned these points earlier. I will skip this slide.